Good morning and welcome. For those of you joining us from warmer parts of the country, we're now entering the beautiful season in Boston. No, really, this is actually kind of nice. So good morning. For those who I don't know, I'm Sandro Galea, and I have the privilege of serving as Dean of the School of Public Health here at Boston University. And on behalf of the school, I want to welcome you all to today's symposium. Welcome. Public health at core aspires to improve the social, economic, and environmental conditions that shape health. And these conditions are ultimately linked to a range of drivers, including the private sector. For example, the actions of the energy industry shape our air and water. Private finance shapes our economy. The food industry shapes the nutrition and food we eat every day. I think public health has long been successful in working with the public sector. It has been less straightforwardly engaged with the private sector areas like these. Yet it seems to me self-evident that partnerships between public health and the private sector are necessary to create the conditions that generate health. We organized today's event specifically to explore and inform these partnerships. We really looked around and said, these questions are not being discussed, they're not being engaged, and we should engage them, we should discuss them. These are difficult questions, these are complex questions, but they're questions with a lot of potential. And we asked you here today really to help us in that conversation. So thank you for being here, thank you for joining us. We are very happy to be here today with our co-host, the Boston University Questrom School of Business, and we are glad that the Dean is, where's Dean Fournier? I thought I saw her a second ago, is here with us. I thought I saw her. And we're also here happy to celebrate the 20th anniversary of the dual degree program between the MBA and the MPH, between our school and the school of the Questrom School of Business. And the program really has graduated a generation of students who have linked the public health and the private sector. And we, both schools, have learned much from each other in doing so. Before we begin, I just want to say for 2 seconds, make a couple of acknowledgements. Events like these are never possible without the work of a lot of people behind the scenes, in particular the Dean's office staff and the communications teams who make such events happen, with particular thanks to our events manager, Lindsay Muragver, and our Dean's office special project manager, Meredith Brown. So there is a lot of work that goes behind these things, so I want to say thank you right up front. And now, before I turn over the stage, I want to acknowledge that this day really is the intellectual work of Dean Mike McClean. Mike is the Associate Dean for Research and Faculty Development and a Professor in Environmental Health Sciences at the school. And for the past 3.5 years in that role, Dean McClean has both been building up our work in research and building the foundations for our school to do ever more interesting work, but really has been pushing the boundaries on thinking about how is it that we do that in partnership with the private sector and public sector. And this emerges from a lot of thinking that Mike has done. So it's really a pleasure to have him lead us through today. Mike.
Thanks so much. Good morning, everyone, and welcome to the Boston University School of Public Health. I'm so glad you could all be here with us today. In addition to our faculty, staff, students, and alumni, we're also very pleased to welcome guests from outside BU. We have guests from the public sector, the private sector, as well as from other universities. In particular, I'm pleased to be hosting a group of my colleagues who also serve as Associate Deans of Research at other schools of public health. You see, I didn't realize it when I took on this role as Associate Dean of Research, but there's a bit of a club. We gather in packs, leather jackets, you can imagine. Well, that's not exactly true, but what is true is we do gather a couple times a year to share information with each other, to establish best practices. And private sector collaborations is a topic that comes up in our conversations time and time again. In fact, in our June meeting, we noted that when our students graduate and secure jobs in some sector of the health industry, we're delighted, and we celebrate that as a really wonderful success story. But if that same graduate in their new role then turns around and comes to us with a possible research collaboration, we don't necessarily react with the same enthusiasm, and it's a moment of pause to think, okay, how can we make this work? So at all of our schools, we're looking for opportunities to advance our research by way of partnerships that maximize the impact of our work. And at the same time, we know there are challenges and possible pitfalls that need to be considered and navigated. So I think we're all here today to try to learn from each other as we try to balance these competing forces. So I'd just like to take a moment to provide an overview of the day's agenda. First, we're going to start the day hearing from our two plenary speakers who will provide a bit of a historical perspective on private sector collaborations in the domain of public health. Next, we'll have 3 sessions focused on specific topics of alcohol, e-cigarettes, and nutrition. And then in the final session of the day, we'll have a panel discussion focused broadly on the health industry. And this seems especially appropriate given that we're holding this meeting in Boston, which has really distinguished itself as a hub of health innovation and technology. So I'm very grateful to our speakers for their willingness to bring their different perspective to this conversation. And for all of you in attendance, we hope this will truly be a conversation. So we've built in time for all of you to contribute your comments and questions. Thank you all again for being here. So with that, it's my pleasure to introduce our first plenary speaker, Professor Amy Fairchild. Professor Fairchild is the Associate Dean of Academic Affairs and a professor in the School of Public Health at the University of Texas A&M. She's a historian who's worked in the field of public health ethics and policy with a broad focus on the social forces that produce disease, shape policy, and determine societal responses. By considering the perspectives of both history and policy, Professor Fairchild fuses these frameworks of analysis to craft a new, historically grounded way of thinking critically about public health problems. Please join me in welcoming Professor Amy Fairchild.
Thank you, Michael. Thank you, Sandro. Thank you, Boston, for having me here. This is turned on, correct? Okay. So I struggled with this title, and I think it's gone through about 15 different titles, and I settled on this one because I think it captures the narrative that we probably have in our heads, that it probably evokes the idea that corporate relationships, private relationships between the academic sector and the private sector are problematic, are corrupt. And so to prepare for today, I went back to look at the history of the relationship between academic, not just academic public health, but academic scholarship, and both the public sector and the private sector in terms of funding. And the history is more complicated than this title would suggest. But in fact, this title does capture the sense of history, but it is not a history in which it's simply that funding from industry has been suspect, but funding from government has also been suspect. So by way of, this is my clicker, right? So by way of disclosure, because I'll end talking about the importance of disclosures, let me just tell you a little bit about myself and my perspective. So I'm a historian who's focused on the ethics of public health. I tend to be drawn to tensions in public health, so I'm a splitter rather than a lumper when it comes to questions. And I'm convinced of the need for broad-based structural and policy interventions in the field of public health. But I'm also convinced that science and values are intertwined. And even though George Annis doesn't like it, I'm a dyed-in-the-world public health paternalist, but I balance that with this admiration for the power of social movements and the ways in which listening to the populations affected by disease can moderate the actions that we take and inform public health action. And I like it when I change my mind. So that's my kind of broad intellectual background that I bring here. Let me just go back for a second. But I also have sort of 3 specific perspectives that shape my thinking about this topic. So I was at Columbia University for 21 years. During a period of time in which there was tremendous skepticism about the corporate production of disease, in which there was enormous debate about what the relationship between researchers and industry could and should be. I had a colleague who was front and center as a historical, as an expert witness in a number of cases involving industry. So while I was not involved, I watched these battles from the sideline, the battles over silicosis, over lead paint, over vinyl chloride, over asbestos. And the intellectual question that was at stake was objectivity. When you defend industry or when you attack industry, how does that positioning shape your capacity to step back and also have a complicated, nuanced view of the history and a complicated, nuanced set of research questions. During this period of time, the school was also debating the question of whether or not to prohibit taking any funds from the tobacco industry. So this was after the creation of the Legacy Foundation and as a part of the Master Settlement Agreement, and one of the conditions of taking legacy funding was that your school couldn't take any tobacco funding. And while no one at the school was interested in taking tobacco funding, we were very concerned about the notion that we could be prohibited from taking any kind of funding. So it began a huge school-wide debate about censorship. I've also been engaged, and so this is how I know both Derek and Michael Siegel in the debate over e-cigarettes for the past number of years. So I appreciate the pressures, not only that industry can bring on researchers, but also that a community of scholars, the kind of peer pressure that a community of scholars can bring to bear on one another as well, particularly if you're adhered to particular scholarly orthodoxies. And now I'm at a public land-grant university. So I've moved from Columbia University to Texas A&M, and we have this explicit mission to engage with the private sector. And we have a long history in terms of agriculture and engineering of developing explicit partnerships. And the system as a whole is very invested in this. So it's against this backdrop that I want to frame the discussion in terms of trust over funding and how we had viewed funding itself over the course of about a century. And so the central question I'm going to ask is, how have these perspectives in terms of interest evolved, and what are the lessons? So the backdrop, and I'll do a kind of history in a flash here, is that beginning in the progressive era, late 19th, early 20th century, public health and this nation as a whole developed this enormous belief in objective truth. And it was grounded in the notion that progress was inevitable and that we could rely on science and the unvarnished opinions of scientists to tell us the truth and lead the nation forward. It was also a moment during this period of time in which public health was on the cusp of professionalizing. So the public health activities that were happening during the late 19th through the early 20th century were really dependent on the broad collaboration of doctors, sanitarians, engineers, evangelicals, housing reformers, and industrial philanthropists. So a lot of the money for public health interventions came from industry in the form of foundations and in the form of wealthy donors. Around the First World War, though, at least in some academic circles, this notion of progress is shattered. There's the historian Clifford Alver wrote that all the spawn of hell roamed at will over the world and made it a shambles. So the academic community, and I'm going to focus on the historical community at first and then broaden out a little bit, became seized with this idea that perhaps we don't stand back from afar. Perhaps we need to question this idea of progress and understand that all knowledge is rooted in particular times and places and relationships and values and ideologies and purposes. That these are all of the things we have to question when we are looking at knowledge. And the historian Charles Beard, who was at Columbia, began to talk about the fickle and mutable nature of truth. And so historians began to challenge the idea that there was any such thing as objectivity. And again, Beard argued that we also have to judge it in terms of its broader social purpose. And he wrote, "The history which does not emerge into the living present is sterile when viewed from the standpoint of public need." And so public need becomes an important yardstick by which historians start to measure their own work in some sense. And of course, responding to public need involves engagement in public life, and the public life that shapes questions and perspectives. And it also raises questions of what's the price of that engagement. So for historians, in the interwar period, the price was, despite this ascendance of belief in science and technology. Oh, that's my progressive era slide. Okay, here we are, the interwar period. The idea of progress is challenged, but historians also understand, that they too are influenced by donors. Wealthy patrons had control over appointments. They had control over salaries. And in a period of time in which historians and other academics made very little money, they relied on textbook sales. Well, publics and public interest groups wanted to control the narrative in textbooks. Historians did commission biographies, and the relatives, or sometimes the individuals themselves who commissioned those biographies, wanted to control the story. And particularly in the context of post-World War I and the Red Scare, historians began to understand that the ways in which they could frame history, if they were going to be engaged, if they were going to accept funding, was going to be constrained in some way. So one historian wrote that the author who seeks to picture the past as it really was, to tell the truth without regard to present-day sentiments or sensibilities, can hardly escape incurring the characteristic pains of martyrdom. And so Peter Novak, who has written The History of Historians, writes that historians regularly adjusted their textbooks to meet criticisms from local, regional, religious, ethnic, or patriotic pressure groups. Now, I've been using the example of history because of its engagement in with these questions of objectivity, which is fundamentally at stake when we think about discussions of the kinds of relationships that we have with both the private interest and public interests. I start with history because we've taken the perspective that all knowledge needs to be historicized, that any relationships need to be put into broad social context, and we have to ask this fundamental question of what's the purpose of these relationships. But also because of a long-standing concern of historians with power and the power relationships that emerge from relationships with industry and the state. So I hope this sets the debate for the broader debates, I hope that sets the context for the broader debates that are going to attend the creation of a powerful national government post-World War II, where the big theme is the rise of the central state and the rise of both public and private sources of funding, both of which have been questioned at different moments over time. But let me begin with World War II, when there was this profound skepticism on the part of not just academics, but society as a whole, that any kind of research money could create a conflict of interest, that any kind of partnerships were potentially problematic. So federal funding was considered to be improper, if not unconstitutional, and it threatened to make scientists the intellectual slaves of the states. Now notice we're talking about federal funding at this moment of time. And that's a powerful word. To talk about being a slave of the state, it's a jarring word, particularly in the context of a war that's really over racism, in which African Americans are joining the army and fighting for freedom, in which we're about to engage in a civil rights movement in the United States. But it's one that captures the sentiment of the time. And the backdrop is concern over the dramatic growth of the federal government and the ways in which it challenges the idea that it's local communities that should be the best stewards of the public good. But industry funding is also considered to be just as tainted. Academics worried about becoming the handmaiden for corporate or industrial research that might result in the corporate control of many of our schools. And this is ironic because this is coming on the heels of Herbert Hoover and a commitment to the notion that public-private partnerships, prior to the Great Depression, prior to World War II, we're going to be the way forward. So, post-war, though, what war does is it brings scientists into government. It brings scientists into government war agencies, and post-war, they go back to their universities. But they continue to serve, as they had during war, as advisors to these agencies. And they help to shepherd in this era of federal funding to universities in the form of project grants. And project grants were a way forward because, from a federal perspective, a project grant was a way to give universities funding without funding education. You could fund specialized science and know where that funding was going. From the perspective of researchers, the project grant addressed suspicions that government was going to intervene or try to control science. And more important, it would be scientists, peers, and not government bureaucrats who were going to be the judges of those research fundings and who were going to be the ones who determined the dollars that would be put behind research. Nonetheless, in the post-war period, the majority of the $31 million in research funding that is going to universities is still coming from private sources. In 1945, the NIH budget was $180K. By 1947, it's grown to $4 million, but that's still not a very substantial amount. But the scope and the scale of federal funding is going to accelerate and deepen in the 1950s in the context of the Cold War. During that period of time, in 1950, the NIH budget is $46.3 million. And by 1955, it's $85 million. And I think we kind of know the history of how NIH funding goes from that point forward. So federal funding in the form of research grants becomes the norm for academic institution in the form of project grants. Only 6 to 8% in the early 1960s of research funding is coming from industry support. And this is really remarkable in a country that's one of the world's leaders, one of the industrialized democracies in the world, that so little funding is coming from research. It's also the beginning of a period of public skepticism about the limits of federal support. So this is Dwight Eisenhower, who was president until 1961, and the thing that he writes is that he's talking about the threats to the free university. And the key thing that he says is that the prospect of domination of the nation's scholars by federal employment, project allocations, and the power of money is ever present and gravely to be regarded. And then he goes on to say, but we also have to be alert to the equal and opposite danger that public policy itself could become captive of the scientific technological elite. So it is we too who become objects of suspicion during this period of time in the 1960s. And social science in particular is one of the things that comes under attack as purportedly promoting the notion of socialism. And it is true that during this period of time, we have the rise of new left historians, new left scholarship. Some were coming from the most extreme wings of the student movement that coalesces around the civil rights movement. Others had been red diaper babies or red romper toddlers and had been in some way either very seriously engaged or through their parents engaged in either the Communist Party as teens or with social democratic organizations in the United States. Some, however, were still relatively conservative academics, and they stuck with this orthodoxy of scientific objectivity. But what's interesting is that during this period of time, is that those who were challenging the military-industrial complex continued to argue. They argued about the importance of understanding knowledge and context, but they also promoted the idea that there was objective truth. And it was they who understood the truth. And what truth required was disclosure. It required revealing what had been hidden. And so the social scientists also go on the attack and start to ask unsettling questions about science and power along two important axes. First, although by the 1970s, only about 2% of research support is coming from industry. So again, these partnerships are still very limited. University scientists were developing a stake in industry. So on the one hand, there is skepticism about university scientists themselves. In 1968, in his book, The Closed Corporation, James Ridgway argues that professors were not only conducting university-based research, but then setting up their own companies, using public resources for private gain. And I'm going to read a passage from his book here. Again, this is 1968. As power brokers, the professors act with one hand in the university and in the other in the big corporation. They move in and out, using their prestige as scholars to advance the interests of the company, or on the other, using their influence with the company to help the university get research funds. And Sheldon Krimsky has argued that during this period of time, this was not really grounded on notions of social responsibility. This was about pragmatism. And so Sheldon Krimsky writes, no proponent of social responsibility yet argued that conducting research for industry would serve a useful social purpose, that the development of new products for the improvement or manufacturing techniques had a bearing on the public weal. So that's one theme there. But there was also skepticism about government itself. First and foremost, the things that government might do with academic research. So particularly in the context of the Vietnam War, concerns were raised about the military influences on higher education, including ROTC officers, concerns about weapons and the ways in which universities might become part and parcel of creating a military state, and the ways in which universities might be engaged in classified research. There were also concerns about the ways in which government might censor science. So in 1978, Don Price in Daedalus writes a piece called Endless Frontier or Bureaucratic Morass. And the thing that he argues is that, and I'm going to read to you from this article just a little bit too, it is much more dangerous to the federal funding is much more dangerous to the essential freedom of science than regulatory red tape or pressure for the egalitarian distribution of funds. So he's worried about a kind of political pressure that threatens to bring about thought control or ideological conformity. And he's worried about the constraints that government might place on the substance of research. And it's not so much that he's concerned as we are in our current era about drilling or other things that happen behind the wall, about the creation of the disparagement of science. Rather, he's concerned that politicians, political elites believe in science. They understand science, and once they believe it, he writes, it's inevitable that they should try to control practical outcomes by anticipating the effects of research and manipulating it in one way or the other. So that takes us through the 70s, where we have you continue to have these competing concerns. No matter, you're damned if you do, damned if you don't. No matter where the funding comes from, you're going to be suspect. And this brings us into the 1980s, when this nation became very concerned that we were falling behind. We were falling behind in terms of innovation. And so this is a period in which there is a robust amount of federal regulation, federal legislation, that incentivizes academic industry partnerships. It's also a period of time, so it's a period of expanding industry funding. But it's also a period of time in which we become very worried now about corrupting the university mission. And from the early 1980s into the 1990s, you have a number so paralleling these federal incentivizations of public-private partnerships. You have a series of public hearings, and Al Gore was central in these, that are questioning what these partnerships may be doing to academia and the ways in which they may be limiting the free exchange of information. The Office of Technology Assessment worried, for example, it is possible that the university-industry relationships could adversely affect the academic environment of universities by inhibiting free exchange of scientific information, undermining interdepartmental cooperation, creating conflict amongst peers, or delaying impeding publication of research results. So in a famous piece in Science in 1982, this notion of the academic industrial complex is put forward. So this brings us into the 1990s, where David E. Lewis, who worked for the EPA for a number of years, begins to start to talk about the way in which government itself is constraining results, repressing data, repressing results that it doesn't agree with, showing a lack of tolerance for dissent amongst government scientists. And again, he was at the EPA, and the conclusion that he comes to, and he is somebody who had worked both with industry and government, is that although corporate influence plays a major role in corrupting science, the federal government has a much larger impact because of the resources it controls and the power that it wields. And that's the conclusion that he comes to in this period in the 1990s. And then this is the period of ours, I think, is the period of deepening distrust from 2000 on. And this is where the red diaper babies have their revenge. Those folks who were trained in the 1960s and the 1970s begin to produce these powerful exposés of industry manipulation of science, about tactics for manufacturing doubt, about the systematic intimidation of experts who challenged industry, particularly as expert witnesses in court. And those are just some of the sort of the great landmark books from this era. But I was also struck in looking at this period from something from the Office of Research in Integrity. And it was this notion that we have to, yes, focus on disclosing funds, and we all have conflict of interest forms that we fill out, but we also need to begin to think about intellectual conflict of interest. And I think this is where this really resonates with me with this early history of historians and the ways that historians have thought about needing to historicize, contextualize the work of everybody. And what the ORI writes is that if a researcher holds strong personal views on the importance of a particular area of research or a set of research findings, those views should be disclosed so that others can take them into consideration when judging the researcher's statements. The same is true of strong moral convictions that can influence a researcher's scientific opinions. And so this idea has been at the core of my own work on e-cigarettes and harm reduction. So one of the things that I have done is not contribute to the science, but rather try to identify the ways in which national perspectives on addiction shape intellectual orientation. The UK has a very different perspective than the United States does, in part because of a tolerance for the notion of addiction, but also identifying the often implicit, the often unstated ethical norms that undergird what those who are involved in the debate even begin to count as evidence, and then how they interpret that evidence. So looking back, I would say that the lessons of history are that it's the damned if you do, damned if you don't lesson. Both federal and industry funds trigger skepticism. Governments, industries, and peers are capable of manipulation, intimidation. All are capable of manufacturing doubt, of failing to tolerate dissent, departures from orthodoxy. But that doesn't mean that they're all equal. And key industries have been the subject of profound mistrust. Certainly the tobacco industry is the specter that haunts the e-cigarette debates. And so Bhavin Sampot and Ron Baer asked this question that I think we need to keep in mind today is some funding off limits? Are some partnerships off limits? And I'm sure Derek is going to address this question in part two. But then the other lessons are that science is a social practice. Values are embedded in what we do. And funding matters, but our analyses can't be limited to funding sources. They can't stop with, we have to be skeptical of industry partners. We also have to be skeptical of government partners as well. And as Sandro mentioned at the outset, there is this mounting imperative to have an impact outside of academia. So if those are the lessons, the lessons from history, the lessons of history, the questions from history that I think we can ask whenever we're considering these relationships are, what are the questions that are not being asked, that are not being funded? What evidence of skepticism do we see in these partnerships? What kind of independence of thought is evident? And one of the things that's been suggested is looking at patterns of funding and perhaps limiting funding more than one time from a particular source, particularly if it's an industry or a corporate source. But we also need to think about the context in which our individual intellectual commitments are forged, the systems that we are embedded in. And certainly now, one of the things as academics we have to worry about is the dependence on extramural funds. And it's different at a place like Columbia, where the expectation was increasingly to raise 70, 80 or more % of your salary in funds than it is in a place like Texas A&M, a land grant institution, which has a long-standing commitment to populations and to industry partners. And we need to find ways to ensure transparency, not just in relationships, but in journals. So are the priorities and values that guide our work made explicit, and are they owned? Whoops. So I think that means that I'm done. But my major point is that we need to contextualize always. Contextualize in terms of values and ideology. And I don't use the word ideology in its pejorative sense. Oh, that's ideological. I use it in its kind of robust sense, in which ideology represents, we hope, a coherent way of understanding how the world is and envisioning how the world ought to be. Thank you. Now the drilling stops. So I think we have time. Michael says we have time for a question or two, or a comment or two. Yes, and if you would, please identify yourself.
Hi, I'm Corinne Pegace. I'm the Associate Dean for Research at the University of Iowa. And before coming here, I looked up what kinds of agreements we have, and the vast majority of ours are data use agreements and memorandums of understanding that don't involve the transfer of money with that private industry. I'm curious how you see the ethics differently, or are they different when the work is paid for by the industry or when it's paid for by a variety of other sources?
Well, my question to you would be, I would want to hear, rather than me giving an answer to that, I would want to hear how others have answered that question. Are the ethics different if there's no money that it's exchanged?
I'm at the University of Maryland School of Public Health. That's my personal opinion, not institutional. But I like the question that you're asking because we also have a similar pattern. I would be interested in the publications that come from those analyses or subsequent grants in order to be able to see the full cycle in answering some of the more holistic questions that you're raising. So I haven't followed that, but I'll look at it now when I get back.
And I'm thinking of something that's happened at the University of Texas. It's not industry, but it's a relationship with the Veterans Administration, in which a number of professors have been told that they're no longer going to have an affiliation with the VA, and along with that they lose all their data as well. So I think that it does come with questions of the ability to have access. It raises the question: well, how does that shape in some way the kinds of questions we ask and the kinds of results that we give in order to maintain that access?
Okay, thank you
Thanks.
so much. Thank you. So, and our apologies for that disruption. It turns out there's some construction going on in another part of the building that is really beautifully resonating up the HVAC system. So I think we've asked them to put a stop for it, at least until we finish up. So I'm now pleased to introduce our second plenary speaker, Dr. Yao Sodolan. Since 2006, Dr. Sadalin has served as the director of the McClean donation program, which aims to ensure that this life-saving drug reaches the millions of people who need it. Prior to this role, he worked at the Ministry of Health in his home country of Togo, serving as director of the Clinical Laboratories Division. He also taught clinical parasitology at the Loam School of Medicine and has consulted for the World Health Organization. Please join me in welcoming Dr. Yao Sadalin.
Okay, how this works? I hope I will figure it out. It's truly intimidating to speak in French following Amy's talk. So, yes, Professor Galea, yeah? Ladies and gentlemen, thank you very much for inviting me to share our story about the McClean donation program during this symposium. Well, McClean donation program is one of the long-running partnership, public, private, to around 2 diseases, river blindness. How it works? Yeah, 2 diseases, river blindness and elephantiasis or lymphatic filariasis. Onchocerciasis is a disease transmitted by vectors, which causes skin disease, like a lot of itching and skin depigmentation, and also at the end, eye diseases, especially at the blindness. You can see that woman helped by his this young girl. The strategy to fight against onchocerciasis today is to distribute ivermectin for all at-risk population 1 to 4 times per year, so that the disease is interrupted. For lymphatic filariasis, also it's a disease that is debilitating, that causes big legs or big genitals, and is source of stigma and poverty. The strategy there also is to use, in communities where there is no onchocerciasis, two medicines, albendazole and ivermectin, or very recently, ivermectin plus DEC plus albendazole. Noting that albendazole is donated by GSK, and of course, McClean is donated by Merck. Where there is onco, the combination that is used is albendazole plus ivermectin. So, well, all started back in October 1987 with this huge and unprecedented decision by Vojlas, which was the CEO of Merck at that time. The decision was to, following the innovation of their ivermectin, which brand name is McClean, he said that it will donate that medicine for as long as needed, for those who need it. That's, wow. Even the decision was taken before he met with the board. So this is unprecedented, and let's see why this decision was the best to take that during that period. Before ivermectin, 2 medicines were used, DEC and suramine sodic salt. Both require many courses and cannot be used in prevention, like in mass drug administration. Myself, I took them. They have a lot of severe adverse events and cannot be used in public health. Now, even abandoned. They are not anymore used. The major control for river blindness during the 80s was vector control. The goal is to kill the larvae in the rivers using insecticide. And at the end of 80s, this strategy also was facing a resistance of the insect at that time. So it was a very tough moment for the global control. Of course, they were using helicopters, and this cannot be applied in rainforest. During the 80s, you may remember that those are the period where the IMF and World Bank imposed structural adjustment with very drastic public health spending and public spending and consumption. As a result, the condition of the population worsened, and they cannot get access to basic health care. So river blindness is a disease of people that are living at the end of the road, even sometime beyond the road. So they cannot afford to buy a treatment of ivermectin, which per person treated is at that period $6. It's too much for those people. So you can understand why this decision was the right to be taken during that period to fight against river blindness. Well, the goal is to facilitate access of ivermectin, which was the medicine that was proven to be safe, to be effective on the parasite, and which can be used in mass campaign, which means you can distribute that once a year to the whole population at risk to prevent the disease. It came initially under 6 milligram aluminum folio tablet, which you can see the picture at the other side. And it has to be used in 37 countries with a risk population of around 198 million people. So that means the donation need to be given to this population for free. Okay. When the program started, when they took the decision, Merck approached many organizations to see if they can oversee the donation in order to have something more independent and fair. They approached UN organizations. They say, oh, pharma, no way. We cannot. So they find a very innovative way of managing the donation by creating what they call today the Demectizant Donation Program, which is a non-profit based in Atlanta under Emory University. There is a group of experts, of 7 experts, which has a secretariat, and their role is to ensure medical oversight of the donation and make sure that the applications are well reviewed and the medicine are located as needed. They monitor the supply chain and promote good medical practices. So 10 years after the decision to donate for onco, the research in the late 70s found that the same medicine can be used in association with albendazole to interrupt the transmission of lymphatic filariasis. As a result, a resolution was taken in 1997 by the World Health Assembly to calling countries to work towards the elimination of lymphatic filariasis. So following that World Health Assembly resolution, SmithKline now called GSK, decided to donate its albendazole for free to support the global effort. And followed by Merck, who said, okay, because the 2 drugs need to be distributed, we are going to expand our donation to include lymphatic filariasis. So as a result, the 2 companies need to work together because the medicine need to be co-distributed. And they agree, there are 2 competitors, don't forget. They agree to work through a medicine donation program in order to ensure that the medicine are delivered by on a timely manner and also to address any common issue that may be arising following the administration of the medicines. As a result also, they changed the structure of medicine donation program by creating a new position for a physician that can oversee the LF component of the donation. And also appointed 2 experts in lymphatic filariasis to sit on the medicine expert committee. Then from 7, they are now 9. This is a private partnership. Following that, that decision, 31 countries and a target of up to 300 million people will get that medicine for free. They are mainly in Africa and Yemen. So, very recently, as if it wasn't enough, they again expanded the donation to include new countries in order to accelerate the elimination of lymphatic filariasis in countries where there is no onchocerciasis. As a result, the collaboration also needs to be expanded to a pharma that is working on the DEC, because the expansion now is for countries who are eligible to implement the triple drug administration, DEC plus albendazole plus ivermectin. So DEC is manufactured by a Japanese company called Eisai. So again, a very complex partnership, private-private, to support a public health initiative. This is where the program expanded, mainly in Asia. So the program now is, MDP is now, medicine donation program is now global. Around 63 plus countries that can get the medicine. So our main goal, why we are doing all this, is to ensure that the medicine arrives to those who need them at the end of the road, which is not a very, very easy undertaking. So to make that happen, a very complex partnership, public-private, is built, which include the countries, the community themselves, World Health Organization, academic institutions, academics, research institutions, donors, USAID, DFID, NGOs, of course, the pharma, whose role is to provide the medicine. In that partnership, every single entity has to know what they need to do, or it will not work. So we need to ensure that we share the same vision before it can work. And we are very complementary roles, and each need to play its role on a time as is required. As far as the donation is concerned, the medicine are sent to the country is free of charge, and delivered at the warehouse. You can see there, the medicines are in a warehouse in Ghana. Now, to make it reach the community, it has to go from the warehouse to the regional warehouses, or to the district, and from the district to the health facilities, and from the health facilities to the community drug distributors. In fact, what is used is either the trucks or even airplanes in settings where they cannot access is difficult in the Amazon. Motor are used, bicycles, even boats are used to deploy the medicine to the communities. So how the drugs distribution is currently actually organized. In fact, bear in mind that we need to ensure that the drugs are distributed with high coverage before we can have impact. And bear in mind also that the disease is prevalent in settings where there is no access. So, and bear in mind that the coverage of the health infrastructure in those countries is very low, that you cannot get, if you want to use the health structure to distribute, the coverage will be certainly very, very low. So as a result, what is used is a kind of outreach strategy, which use a kind of public-private partnership with the community, the beneficiary communities, where they are asked to ID their volunteers, which will be trained by the health system, and then will be provided the commodity, the medicine, to distribute to their family, in bracket, free of charge, free. They will do it on a voluntary basis or with very few motivation. You can see here that the distributors are there, being trained by the nurse, either in Malawi or in the Amazons. Training is key. To ensure a good coverage is obtained, which means good compliance of the intervention, it's important to sensitize the community and explain why they should adhere to the intervention. So we can see there the Minister of Health in one country sensitizing, and you have banners, you have T-shirts to sensitize. The strategy used is door-to-door distribution, where the distributors visit the households, measure the people, and give them the number of tablets they have to take. This young boy is taking, for instance, 2 tiny tablets of mectizan. So they can also gather people in a central point, and they line up and get the medicine during the distribution. What we learned so far, a lot of lessons, but I want to put emphasis on 3. The first one is, in this kind of partnership, you need to be very, very flexible and adaptable. The second one is, be prepared to mitigate if a partner within the partnership is failing. The third is, it's very, very difficult to keep stakeholders engaged in this kind of long-running partnership. 30 years, we celebrated last year, is too much. So be flexible. We realized when we started the distribution of the medicines that it's not easy to maintain scales in villages. So we moved from a weight-based distribution to height-based distribution. Those are innovations, and to ensure that the job is easy for drug distributors who are not health professionals. Also, we moved from aluminum folio to tablet, aluminum folio of 6 milligram to tablet of 3 milligram, because the field people complained that they cannot break the medicines in community settings. And also it's difficult to remove the tablet from those aluminum foils. So Merck was obliged to readapt, to repackage the medicine. Be prepared to mitigate. And the key problem of this program is always funding gap. How to have the money to do training of the health professional and the drug distributor, social mobilization, incentive for drug distributor, and the distribution itself. Those are the key activities, but sometimes we ship the medicine, they are there, but they cannot reach the people because there is a funding gap. And it happened in the past, or even currently, that Merck sometimes has to go beyond the pills and provide financial contribution. Like in 2004, they donated 1 million to support distribution. Even in 2007, a matching fund with World Bank, $15 million to support the program in Africa. And 1 million 2 years ago, 2 years ago, in fact. And last year, 300 million. To all those initiatives is to ensure that they fill the gap. So keep stakeholders engaged for a program that is running for 30 years. That's very difficult. You know, they always say donor fatigue, and new leaders who were not there during the vociferous period are coming on board and may not have the same enthusiasm or commitment. We need to keep them engaged so that the program keep running. Also, the results are not or are very slow to come to keep people, give people a kind of hope that we are reaching something. These are very challenging. Or we are so effective that the mobility is becoming very, very low. Like there is no more people that are having, they are getting blind or having skin diseases. The disease doesn't exist anymore. So as a result, difficult to ask people to take the medicines. Look, every year we are raising the bar. Actually, last year, for instance, 850 million tablets were shipped to support onco and LF elimination globally. This is when we will be reaching a billion very soon, tablet. Well, it looks like we are making some progress. Actually, for river blindness, when the program arrives in any community, it's clear there is no more new case of blindness or skin disease. Currently, more than 5 million people are off treatment because the transmission is interrupted and the treatment is stopped. Colombia, Ecuador, Guatemala, and Mexico were verified free of river blindness in the Latin Americas. And also treatment is stopped in many foci in Africa. So it's rewarding. We are making some progress anyhow, but it's not such, the pace is very slow. The goal is to move people, countries from the red to the 5-star countries and certify them or verify them free of river blindness. This is a picture of a celebration in 2016 in Guatemala. In the presence of the president, they are celebrating the country being verified free of river blindness forever. That's a big achievement. And for lymphatic filariasis, the goal also is to move the countries from red to 5-star countries. And my home country, Togo, is one of them in the 5-star countries. So we are making some progress, though it's slow to reach. Well, the goal we have in this partnership is to ensure that everyone bring on the table what they can bring or what they promise to bring, so that these kids from rural Malawi have a better future. So I thank you for your understanding. Yeah. Okay. So questions?
So I think one of the really interesting things about this history is the degree to which, after Merck develops this drug, nobody wants to partner, and the WHO is not interested. And it goes back to your point about vision. So can you talk a little bit about what was done in the beginning to create a shared vision and create these partnerships?
It was also part of the Merck strategy. Merck's strategy was because they know that the medicine will be there in the country, but will never be distributed, which actually is not what they are expected for goal. So they started first working with NGOs, and the NGOs were the biggest segment in that created that kind of commitment, even at this country level, because they were working at the grassroots and were interacting with the government and created this coalition and sensitization and say there is an opportunity. You have the medicine that are there, and what facilitated also is the OCP program, which is actually the Onchocerciasis Control Program there in West Africa, which was facing the resistance of the vector to the insecticide. And they have no choice but collaborate, get into that partnership to use mectizan for onchocerciasis control. So those are some of the key facilitating factors that created that partnership, and the vision for them is never again blindness related to onco. Yeah. Yes.
Hi, Derek Yach. Just maybe a comment on some of the untoward effects. I was speaking to Amy's points. I saw directly the initial opposition from the Essential Drug Program in WHO to the very nature of having this happen. But I think that dissipated pretty quickly when you started seeing the land being cleared and farmers being able to go back to work in vast territory. And it did become the landmark private-public partnership, I think, of the last many decades. And many people may be unaware that the bronze statues commemorating it stand outside WHO, the World Bank, the Carter Center, a number of academic institutions. I took, at the time, my boss, the CEO of PepsiCo, when we were meeting at WHO, to the statue to ask what would be the equivalent of what the food sector could do to have the size of impact. I'm not saying there was an answer, but there certainly was a lot of inspiration that pharmaceutical private companies took. And I suspect even the discussions that happened decades later about the ability to really lower drug prices for the poorest part of the world had at the back of their minds what actually came out of that mectizan program all those years ago.
Yeah.
Question about partnerships and a question about specifically partnering with academics in the disciplines of business. At the bottom line, it seems that part of your case analysis stems on distribution, and we have academics who specialize in operations and supply chain management with very sophisticated thoughts about optimizing those systems. Is that standard practice? Is that part of the solution? Obviously, I'm coming from the academy and the School of Business, and I'm curious about that. Thank you.
Well, actually, the academic were, I have to say, very critical in terms of facilitating or taking this medical intervention to the at the grassroots level. Like in many countries, or in some countries actually, volunteers, community people cannot distribute the medicines. Moving from scale, which is how the medicine is innovated, from scale to dose pool is a fruit of operational research done by academics, and which actually were able to see a correlation between a range of height and weight, so that distributor can do their job with a kind of margin of safety and quality and make the program running very smoothly. Issues like incentives or distributor attrition, things that need to be documented by the community, by the academics. So their role is very key in terms of how to implement and even monitoring the success. Yeah. Okay. Thank you.
All right, so it's now time for a brief break. We're going to plan to reconvene around 10, and please join me one more time in thanking Professor Fairchild and Dr. Sadalian.